Thank you, Dr. Prasanna. So I'll be sharing my screen. Let me walk you through the traditional fundus examination and the challenges that we face. About 1.5 centuries ago, we had to rely on the postmortem specimen for ocular fundus examination, and 1850s marked the golden age of ophthalmoscopy when direct, followed by indirect ophthalmoscopy was invented, and the advancements followed till date. So in your clinical practice, we have direct ophthalmoscope, slit lamp biomicroscopy with various lenses, indirect ophthalmoscope, and the digital fundus photography for your fundus examination. Direct ophthalmoscope used to be very popular because of its wide availability, low cost, and portability. And the working distance was 1 to 2 centimeters, and it had an excellent magnification of 15 times. The image formed in the direct ophthalmoscopy is erect virtual image, which is projected behind the subject's retina. And you have various filters in direct ophthalmoscopy, and you can use the direct ophthalmoscope for pediatric examination, patients in wheelchair, and lying down patients. The limitations are it had a field of view of only about 10 degrees, and media opacities compromise the view of fundus. And stereoscopy was not possible because it was seen monoclearly. In direct ophthalmoscope, the working distance is about 40 to 50 centimeter. It has a good stereopsis because it is viewed binocularly, and a larger field of vision of about 40 degrees. And good illumination allows us to see even in relatively hazy media. The magnification is 2 to 3 depending on the lens used. If you use a 20 diopter lens, you have a magnification of 3 times. And the image is formed between the condensing lens and the observer as an inverted image, real image, which is laterally reversed. You can also see the patients who are bedridden as well as in theater. But the limitations are it is difficult to master. It gives us an inverted image, and because of the relative lack of magnification, subtle glaucoma disc changes and RNFL defects, few dot hemorrhages, and small microaneurysms will be missed. Even early NVEs can be missed, and it is impossible to see a indirect ophthalmoscope with a small pupil. This is a comparison between the field of view of a direct ophthalmoscope, which is 2 disc diopters, and indirect ophthalmoscope, which is 9 disc diopters. Now, slit lamp with various lenses like 90 diopters, 70 diopters, and 60 diopters is more popular nowadays. It has a larger field of vision of about 35 degrees, lesser distortion of the image, and we get a 3D stereoscopic view because we are viewing it binocularly, and it can also be seen in a relatively hazy media. We can manipulate the image with the help of the magnifiers and the filters that is present in the slit lamp, and magnification is about 5 times. And if you have an image capturing device attached to your slit lamp, you can even document the fundus of the patient.
Activity number कितनी है?
The vessels and the macula seen in the 90D examination. But it is impossible to see the 90D examination in a very small pupil, and intense light is uncomfortable for the patient. And stereoscopy, even though we say that 90D, we have a stereoscopic view, but in less than 3 millimeters of a pupil size, stereoscopy is not actually possible, which is very important in glaucoma practice. And also it needs practice. So coming to the documentation part, documentation is very crucial in progressive conditions like glaucoma and diabetic retinopathy. The glaucomatous disc can be documented as shown in the figure, the circle representing the disc margin, and the disc is divided into 16 quadrants with the help of 4 vertical and horizontal lines, and you have to mark the cup as well as the vessels. And vertical cup disc ratio is also marked. You can see the follow-up in which both the vertical and horizontal disc cup disc margin is increased. Now everyone is shifting to the electronic medical records. So when you document it, you have to write it very clearly and descriptively. But in reality, do we really do that? In reality, we end up marking something like this, or even much worse like this. And in EMR, just marking it as a 0.6 cupping or a 0.75 cupping with an inferior notch and inferior RNFL defect doesn't give us a real idea of what exactly the patient's fundus looked like. And it has an inter-observer variation. A 0.6 seen by one observer will feel like a 0.7 by another observer. So progression analysis is slightly difficult because in first and second visit, you may remember what the patient's fundus looked like, but definitely not in the third and the fourth visit. So coming to the difference between the undilated and dilated examination, in undilated pupil, you're ought to miss some subtle findings like an early RNFL defect or even the wedge defect, microaneurysms, and the findings which are away from the disc and macula. And patient cannot actually reveal the history of having a diabetes, so you may miss most of the finding. So dilatation is mandatory, but when you dilate the pupil, it has its own problem like hair, glare, and it will be difficult to drive and work on the same day. And tropicamide also gives you allergic reactions. It can have stinging sensation, watering, redness, tropicamide allergy, and rarely you can also have the heart arrhythmias, flash pulmonary edema, and you can even end up in an ICU. And in a busy OPD setting, dilatation is definitely going to take up the waiting time of patient as well as the doctor. Especially in this COVID pandemic, we need all the patients to move fast out of the hospital. And finally, direct ophthalmoscopy is not recommended in COVID era because you see the working distance is only 1 to 2 centimeter, and you invariably go and end up touching the mask of the patient. Even in 90-day examination and in direct ophthalmoscopy, to get a stereoscopic view, you are going to touch the patient's mask. So the question is there a better way around? Thank you for your attention.